apologies for absence. We've got apologies from two of our non-exec directors, Paul Green and Vikas Kumar, who was able to join us today. And apologies again to people in the room and anyone online that we have at the 1.5, which is policy report. I'm not going to go through it line by line, obviously, but within that report, for anyone who hasn't got it in front of them, I say quite a bit about what's happening in the country and locally back in August, beginning of August of this year, around riots, disorder, racist behaviour that was taking place. And within that, I'm supporting the activities and action of CNTW insofar as the support and care and humanity ensured, I think, to its staff and also to the communities and patients that we serve. But within that, wanted to reiterate some of the messaging that went out from CNTW during that period, thanks to the team that were around at the beginning of August, which was again about showing that support to people who may be feeling vulnerable at that particular, but absolutely condemning racist behaviour of any kind, and obviously adding emphasis to that not being tolerated within the CNTW. Beyond that, I talk about the work that I've observed that the trust has been doing around its culture, and welcoming that work, and reiterating really and trying to take us back a little bit to our trust strategy with you in mind. And again, it's online for anyone who would want to read it. Within that, we talk about our values about being caring, compassionate, respectful, and honest and transparent. And I think that was particularly timely given what we saw in August, and actually the work that the trust is doing. And to me, what that's about is we have a lot of things to do as a trust, but how we do them and the way we go about them is really a key function, I think, of the board. And that checking and balancing around the values and culture of the trust is something that's really important. So I talk a bit about that within the report. So I talk about how we think as well. And then beyond that, there is a reminder to some extent, but a really important evening that we have once a year at CNTW this year on the 27th of September, which is our Staff Excellence Awards evening. Congratulations to all those people who've been shortlisted. We look forward to seeing who the winners are, and the winners will be on the night. But there will, again, the number of people put forward who sadly all of them can't be shortlisted, but the amazing work that clearly takes place across the trust by teams, by individuals, by services is quite phenomenal. And I think when we talk about some of the things that we'll probably talk about during the course of the meeting today, that when things are not going so well and things we'd like to improve, it really is heartening to see some of the fantastic work that goes on. We'll hear more about that at those Excellence Awards. It's our annual general meeting the day before, on the 26th of September, where it's an annual members meeting and an annual general meeting, I should say. It's got a dual purpose, and everyone is welcome to attend that and to hear about again what the progress the trust's been making and the things that we are doing. And we'll have it over the course of the last 12 months and over the course of the next 12 months. There's a section around fitting the outcome of the Fit for Purpose review, which essentially is about the board and the stringent processes that the board is required to go through to make sure that members of the board are fit and proper to sit on a public board. With CNTW, I'm pleased to say that that's now happened for this year, and there were no issues to be raised or brought up. Then I talk about some of my activity internally and externally, and some of the local and regional meetings. And I think that the overall point there is to talk about the fact that as an individual trust, we operate within a much wider system, as we know that our integrated care board, the North East and North Cumbria integrated care board, we're also working with local authorities, and working with the wider NHS. And it's important that I think as the board members, myself as the chair, James chief executive, that we stay connected as we do, and that we report back to the board around the things that we do in that regard to make sure that relationships, systems, processes, etc., are as good as they can be. So there's some narrative in the report about that as well. And at that, I will shut up unless there's any questions or comments that people really think. James, chief executive.
Thank you. Again, I'm recording for this debate, and you'll be very pleased to know, but I will highlight a couple of things. One is, and it's Darren's talked about the disorder and our response. All I want to add to that is extremists win when they spread discord, and it becomes the norm. It isn't the norm. What I was really proud of in the response of CNTW is the response of the CNTW community, the response to each other, and that is something for us to be proud of. And if we continue like that, and we will continue like that, but we bring and we see it for what it is. So I'm very proud of that. Another thing I'm very proud of is that the one thing about this, so we've been awarded or been successful in the bid to be a national pilot for a new 24/7 community hub. I just want to say a couple of things about that. One is that we don't see that as a pilot. That is going to be the new way, and it's going to be the way we do things. And the last thing we want to do is change the way we operate across Cumbria and dismantle it in 2 years' time. So I just want to say that is not going to happen. This is about how we take services forward for the long term. But being part of the national pilot gives a real opportunity, both in terms of getting some additional funding in the system, but more importantly, get a national profile and have the ability to influence national policy. So I think that is a really big opportunity for us as an organisation. And we've got a great partnership across Cumbria with national players, but most importantly with local community organisations, and that's where the real strength in that proposal is. So we'll be coming back to the board to update what is going on there. I won't say much about the rest of the report. I will just say that the report in the Northumberland, Rajesh is going to be dealing with later on. That is really important, and it's really important as well that we see that in the light of the change that we're trying to make in community services, because this is not about creating new hubs. This is about how do we really change the way we support people with mental illness, and particularly within that, whether we get the response right depending on the need. In Baldock-Callicane, we had an example where the response wasn't right in proportion to the need, and the system doesn't help that. The system actually raises the risk of failure, and it raises the risk of letting people like Val go down. So we have a real opportunity to think very differently, and we'll get the right response, the right person at the right time, and that's what we are trying to do. And that fits again in 3.2, which again is guidance on intensive and certain community mental health treatment. And all I'd say to that is one of the things that, and we've done this before, one of the dangers that we can fall into in response to something like Baldock-Callicane today, we become more restrictive in our practice and more risk averse. That's not where we want to go. And the other thing is we think, what we need is we need another team that is going to do the assertive outreach and is going to do that assertive response. But that's what we've done in the past, and then we create a really complicated system where people can fall through the cracks. And again, that's not what we want to do. So it's really important. We really learn from this, and how do we respond, and Rajesh will take us through that later on today. There's a big section of the review of the operational effectiveness of the Care Quality Commission, and that will obviously be a big thing for us and the NHS as a whole, is how our regulator changes over the coming months and years. The last thing I will comment on is the Labour Government Health Policy Update. And just to say, and I won't comment on any of the content of that, but West Street attended the new Secretary of State attended a national meeting of chief executives yesterday, and was very open and very clear about the direction of travel and the aim to develop a genuine 10-year plan, which I see as a real opportunity for us, and a real opportunity for us, again, getting back to that community pilot to influence national policy and say this is the way it could be. So a lot of things coming together potentially. We just need to make sure that we construction them. And the rest of the papers there to be read, and I'm happy to take the comments.
Okay, in that case, I'm going to move us to section 2 of our agenda, which is purposefully ordered around our strategic ambition, so that the next few items are around our strategic ambition 1, which is about providing quality care every day. And we start that off with Louise as our quality and performance committee chair to update us around the activities of that committee.
Yeah. So at the Quality and Performance Committee, as you can see, it was held on the 31st of July. At each committee, we start with a quality focus. It helps make sure that we're hitting the topics that are really important to us. And this time it was about crisis referrals. So we heard from Chloe about the different types of referrals that we have: street triage, places of safety, right care, right place, and the new 111 service. We talked a little bit about how many contacts there are that are referred, and that's about 100,000 a year. We also talked about how we're managing that and how success would look. So we talked about the community transformation steering group, who have oversight, and they have a lot of other people, including service users and carers, looked at what success will look like, which is improved access to care, more integrated care, and the prevention of inappropriate admissions. So we talked about the risks around that, obviously staffing, response times, and ensuring that we have safety plans. That was quite useful. We'll be returning to this on a regular basis. We also talked a little bit about the health and safety exec, who have given us an improvement notice and how that's being managed, how it's being monitored, and that has now become part of the trust-wide safety group. So we'll be watching that all the time to ensure that we're doing what we've said we've done and that it's working. We always discuss the integrated performance report, and I'm not going to go into detail here about that because you'll hear about it as we go through the papers today. One of the biggest problems that we all have is the community services waiting times, both for children and young people, particularly on the neurodevelopmental pathway. We know this is a huge problem, and we have it very highly on our agenda, as it is on the ICS and becoming increasingly so. We talked about the waiting times for working age and older adults, and also particularly about adult ADHD, and that has now got to the point where people joining the waiting list in February of this year are having to wait 7 years, which is not what we want to happen, obviously. So that will constantly go back to the ICB, because it's not just a trust issue, it's a whole system issue. Safer staffing report we look at, that's giving us greater assurance as to how we're ensuring we've got the right staff in the right place at the right time. We talk about the CQC. Again, it's important to have it here because we look at exactly what we have to do in terms of must-dos and should-dos and where we're progressing. Quality and safety is now in a different kind of format, in the same format as the integrated performance reports, and we'll see how it helps us to clarify our thinking and to ensure that our PSEP aims and objectives are being met. We have a whole list there of additional reports that are received. It's a very big committee, so there's quite a lot that we get through. And I think that the important things that we bring to the board each time is what we're doing, what we want escalated in terms of particularly waiting times, because that's, you know, the priority for us. We're also hoping to put the spotlight on capacity, consent and rights, but that will be done in conjunction with the mental health legislation committee. And I think that's probably where we're at.
Your comments, Louise, and colleague Florence. Just a couple of things for me, just again, just conscious of anyone listening. Louise referenced Chloe in terms of the that's Chloe Mann, one of our place directors. Just to give anyone wonder who Chloe was, and I think just again for a point of clarity, Louise talked about the health and safety executive notice. That's not a notice that's being served on the trust in a general sense. It's around one of our wards, i.e. Milford. I think we're obviously taking very seriously working with the health and safety executive to make the necessary improvements. And I know we've got a special group set up to be able to deal with that. Again, I'm just saying that people online, Rachel?
A quick point about the ADHD waiting list. Is there any kind of indication about whether it's expected that the ICB going to kind of come up with a plan for the whole system? Or because currently the plan just seems to be that partners look at ways to make...
I think the correct answer would be that it can't just be about partners, it's got to be a more system approach, and we will be feeding that back. Obviously, we will give our opinion on how to progress that.
But as it stands, there's no system approach to reducing the ADHD. I think there's a couple of things to feed into that. So there's a second meeting this afternoon, actually, following escalations through the mental health and disability subcommittee of the ICB. There's a number of areas that we put forward as a proposal. One of those is to try and move to a much more primary care front-facing model around early help, support and intervention, particularly around working closely with our education partners for children and young people. How do we move away from just a pure assessment function for that? And how could we concentrate on those people who have other comorbidity or other needs from a mental health perspective so that we see those sooner rather than just adding to a waiting list? So there's a number of proposals we have put forward to the ICB, including some additional funding that's come available for this year and how we could maybe mobilise some of our other third sector partners to provide some early help, support and intervention as well, Rachel. So there's a follow-up meeting to that taking place in a month's time with the ICB.
Well, James, did you have a follow-up question? Yeah. Is there a national discussion taking place around this? Because it's clearly part of African psyche now, isn't it? And I don't think even with the ICB intervention we're going to solve this problem. It's a national issue.
So yes, that's what I was going to say. So yes, there is a national review being led by Claire Fuller, who did the full report, which looked at integrated, well, 3 models of primary care, essentially. And that the model is very looking at this being much more of a primary care led approach. We'll see in ADHD, like akin to something like asthma, and having gradated responses depending on the need. Key with where primary care is at the moment, it's going to be at the end of the report, maybe a challenging discussion depending on what happens around that. But in terms of the principles that we are allowed to approach it, I think it's the right approach. They're also considering that to review the whole society issues as well, and why we're getting the demand that we're getting. So I think it is looking at it from a much more fundamental perspective, and that's welcome. I have to say that it acknowledged some time ago, I haven't heard where it's sort of produce back to and get an update on. I'm actually I'm in a national mental health chief executive meeting next week, so I'll see if I can get an update on that feedback.
Yeah, I certainly think given our own waiting lists and the trajectory of those showing no signs of slowing down, and I know that thanks to we managed to initiate and get that conversation going with the ICB, because that wasn't even that. We go back 12, 18 months, that wasn't happening at all. We were simply left with that openings of individual trust. So I'm pleased that we've moved on to the ICB level and we're having that wider discussion. But I do think we need to understand what the national position is, because it feels like it's not the solvable problem within current resources, while that private national safety, whatever you want to put forward, remains, and the importance of the diagnosis and what that means to people, the things are just not matching up. So I think I'll come back to you when it's question for the public, sorry.
It was just on that point, and we are seeing some providers, indeed there's one in the international press in August, from a secondary care perspective, close to any new referrals until we've got some greater control over what's coming through and that referral criteria. Now, we're not considering that position, but we may need to look at other options around the mitigation of risks. It's interesting that some providers are looking to do that now.
I will come back to you with the public. Okay, with a resident further question, I think I'm going to move on to the legislation. Thank you.
We also met on the 7th of August. The paper we didn't all the papers that set us out the outcome of our discussions, but mentioned the highlights from there. We looked at all the policies in relation to mental health legislation to date. We also looked at the outcomes of the mental health app review visits which are taking place in the period. Checked that the applications being monitored following those. We looked at detentions under the Mental Health Act. In particular, we're required now under the Patient Care and Basic Quality Framework to collect data in relation to the ethnicity of those who are detained under the Act, particularly because there's a suggestion, I think, in the wider data that ethnic minorities are overrepresented in these conditions. So collecting that data and continue to do that and monitor the outcomes of that as it's being received. We looked at a review of panel membership, or screeners panel, who make various decisions in relation to detention on behalf of the trust. Can't go into that at the moment. We also looked at compliance with giving of rights and the capacity in relation under the Act, something which we're looking at in conjunction with the Quality and Reform Committee and the Mental Health Legislation Steering Group. So working with us on that, they've asked the various locality groups to go out and collect the data to what they're doing to increase the levels of compliance that we are seeing shortfall in certain targeting in that area, and it's been continuing for some time. So we're looking to see positive changes in that in the coming months. Within the current risks, the risks we saw were particularly in relation to the recordings of capacity consent under the local forms which we use to let the people who are having detention. And as I say, the steering group will be going out and looking to get details from local groups as to how we're increasing compliance and looking to increase compliance. Mental health legislation training, which has been lagging behind our targets for quite some time, that's actually heading in the right direction. Still not part of the target. We've got 75.2% of the workforce at the moment, which is higher than it has been for some time. We're not, obviously we still need to make some progress in relation to that. We're looking to open up the pathway for people to get access to it. And that's an ongoing test, and we'll keep pushing to see that increase. Challenges in the new and medium term, or now and the medium term. Interesting times on mental health legislation in that with the new government, there should be, or as I mentioned in the Queen King's even past the Queen's speech, there's the mental health bill, which disappeared during the last Parliament, is likely to reappear during this, and so we're going to be looking to monitor how that progresses over the coming months. And that did have all party support in the last government, so hopefully that should be relatively straightforward passage through Parliament. In relation to panel membership, we had a report on current levels of membership. We've got 51 panel members and 10 individuals going through the induction to join that panel. It's quite a healthy number compared to other trusts, and actually a reasonable number compared to the previous groups. Two of those going through induction are from ethnic minority communities, which has been an area which we've been trying to increase representation over the last 12 months or so. So that's a great step in the right direction, but hoping might continue and we can bring other people in with that. It's a difficult sell to get people going into the mental health. The hospital members panel, it's not a group of people are well known in the wider community and people don't know what they do. So the more we can spread the word that there is this group and that the service that people can undertake by joining it, the better. The matters we were going to escalate to the board were particularly in relation to the work that's being done on improving the compliance with the local forms on capacity and consent and the giving of rights. So again, I'm hoping we can report increases in that over the coming months. We're looking at, I mentioned, the panel membership and retention membership, but one of the areas relatively minor, but we previously reported to the board on was on a recent case in the employment tribunal, which suggested that panel members could have employment rights in certain circumstances. We were looking at the implications of that. We were following that up with other discussions with other trusts to the implications there might be, and really understanding whether that impacts our own panel members and whether they may have employment rights or not. That was really the summation of what we discussed. If there are any questions you have, that's not happening.
Question, is there a comment? Thank you. Thanks, Michael. In that case, the main item on our agenda, our longest item on our agenda today is next one, which is learning from the Shanley report, CQC review of health services and health services.
Hey, thank you, Chair. Okay, so I think what I'm going to do is I'll go through the findings from the Shanley report first, the relevance to our organization and what our approach will be. And then after that, I'll go through the findings of the Nottinghamshire Trust Review, as James has made reference to the sad case of Tyne. Okay, could we have the next slide, please? So I think just to put the context, because not everybody might be aware, but in September 2022, the BBC broadcast a panorama program, and they had this undercover reporter who was working in Edenfield Hospital, which is a secure hospital in Prestwich, Manchester. And it reported appalling levels of abuse, humiliation, and bullying of patients. As a response to that, NHS England commissioned an independent report chaired by Professor Oliver Shanley, and basically asked the team to report and for us to understand the wider public as to what took place, how and why, and what could be done to prevent situations like these in future. The report was published in January 2024. And just very briefly, with regards to the how and why, what Oliver Shanley found was that the trust was focused on expansion. There were sort of competing priorities about performance management and reputation, and not enough attention on you. And there was also insufficient, in fact, quite a lack of any understanding and so on. But many families and patients actually felt that when they raised concerns, they were not really believed, experienced unkindness, lack of compassion and respect, and abuse by the staff. Staff actually didn't feel very safe to disclose concerns, and many feeling intimidated, undermined, ignored, or fearful that bad news was not welcomed. I briefly made reference to how there was insufficient oversight on the quality of care and failure to learn. But interestingly, there were also missed opportunities. There were other regulators who knew about some of the things going on, even professional bodies, but nothing really happened. Disproportionate reliance on external regulators, for example, the CQC had rated the trust quite favorably. And I think that was taken as a kind of indication that everything was going well. I mentioned about staff, But along with bullying and harassment, a number of staff were leaving the organization, very poor morale, feeling exasperated, tired, and disconnected from the trust leadership. We have the next slide, please. What was really interesting is when I've summarized some of those findings from the Shanley report, they are not very dissimilar from the Kirkup report, which reported on the tragedies with babies dying in East Kent and the whole system around obstetrics, midwifery, and what was going on. And we all know about how many issues have been identified in that area over the years. The point I wanted to make was that some of the findings from Shanley have been reported previously. But what Shanley wanted to put a challenge was, he didn't want a report which was going to just sit on the shelves. He wanted to make some clear recommendations which could make some change, and I'll come back to that. Next slide, please. I will go through some of the details of the recommendations because they're relevant from a governance perspective for our trust. But before that, fundamentally, Shanley identified these 6 areas, which I think he said any organization has to be focused on. Central to anything we do should be the patient voice, the family voice, the carer voice, which is involved at every level and influencing whatever happens in the organization. We all talk about leadership, but Shanley really identified that along with compassionate leadership, you really need clinical leadership focused on decision making. And if that happens properly, you find that quality will be done well, and you'll have safe services. I've mentioned about quality, I won't go into that, and we'll come back to that in some of the recommendations. Workforce. The right people with the right skills and the right values. And also, does the organization have a plan about what are the people you need? You have to have a learning culture. I mean, since Shanley has reported, now all NHS organizations have to be part of a framework called as PSERF, which is a Patient Safety Incident Response Framework, which has moved us away from investigating and blame to learning. So that is good, but it will only be as good when we know actually how we're acting on it, and we have developed a learning culture. And all these 5 things actually lead to culture. But the reason the culture box also is there are 2 or 3 things which are really important in the context of safety. That's the ability, a culture which allows people to speak up, a culture which is inclusive, and a culture which is just. Could we have the next slide, please? So quickly going through some of the recommendations. There were about 12 or 13 recommendations, but there are 7 which are relevant to our organization. And it is important for the board to be aware because this will form our plan of how we take the Shanley recommendations forward, and will be something which we will monitor through our committees. So the first one was about patient family carer voices and how we respond to them when people experience difficulties. There has been a lot which has happened over the years in CNTW, including the work we've done on involvement, engagement, and so on. But there is still quite a lot to do. And I think one of the things I would say, which is going to take quite a lead into it, is our Trust Leadership Forum's next meeting in September, which is going to get our service user care reference group representatives and the trust leaders together to take this agenda to much more the next level with clear identifiable actions. Second recommendation, strong clinical voice. The trust has done a lot in the context of devolution, of a collective leadership which works in operations and so on. But we do need to go further. We need to develop the clinical leaders of the future, and there is a organizational leadership program which support us, and we do need to strengthen our clinical networks. That is an area we need to go further with. We have the next slide, please. Culture. Now, this is every board in every NHS organization fundamentally sets the tone for the culture and is the guardian for the culture. But I think what Shanley has also challenged all organizations is how do you really know that you're making a difference? And in that context, I mean, Darren made reference in his chair's report to the work going on, and a lot has been going on in the trust. There's some very exciting things which we are working through, but we need to make sure that that work actually is impactful. We know how it is impactful, and it probably will need to come through the People's Committee to make sure that we are making a difference. And I'll come back to that right at the end. And linked to that is our work around cultures, healthy cultures. How do we know the early signs of cultures becoming sadly not good, or at worst becoming closed? And finally, the work related to EDI and quality, diversity and inclusion. Recommendation 4 is what I've made reference to about having the right people with the right skills. And although Shanley talked about the nursing workforce as a group, because that is the biggest workforce in any healthcare organization, was talking about it wider than the nursing workforce also. And it is crucial that as an organization, the work we've done until now, we build on that further and have a clear workforce plan, especially when it comes to our inpatient or our specialist inpatient services. Next slide, please. Recommendation 5 was in relation to the quality of the estate. And the focus here predominantly was about providing a safe environment. At the moment, we have quite a robust structure here about any issues around safety, which involve membership from NTW Solutions, feed into a subgroup of the trust-wide safety group, and as further oversight from the executive management group. And clearly, it's also linked in, if required, with any developments, which then I suppose are picked up through RABA. Recommendation 6, the governance structure. What Shanley found was the governance was very complicated in Greater Manchester Mental Health Trust. There was a lot of information, but not clarity about how information was communicated right from the board to the board. We have done a lot of work in recent months on our decision-making and assurance functions and our risk management functions. We still have to make sure that that actually is fine-tuned so that it is effectively working. And linked to that will be the development of the cultures dashboard. That should give us the triangulation of information along with our integrated performance report for committees and the board to quickly ask the right pertinent questions. And finally, recommendation 7 was specifically to deal with Edenfield, which is the secure hospital in Greater Manchester Mental Health Trust, about looking at quality of care and staffing and skills. And we've asked our secure services to actually review that too, because we do have quite an extensive group of secure services. Can I have the next slide, please? I think was doing that as August is doing. Okay. So the actions I've talked about previously are all now grouped here. I'm not going to go through them again, but what I'm going to say is that the first 6 or 7 actions automatically should be what already is the kind of business got to be. We need to get the assurance support from there, along with identified timescales and impact. With regards to the cultures dashboard and oversight of the integrated performance report, we need to think about there might be some functions which sit at the People's Committee, but some also in the Quality and Performance Committee. And the rest, I think, is more or less ongoing work. And the final slide, please, on this section. I made reference to a cultures dashboard for quite some time now. We are in the process of actually there's a lot of work going on it. These are some of the areas. In these 6 bullet points which you see, you will have metrics under them. And what we will have is, we will have indicators which will tell us that there might be a particular area which might say, for example, we might find that there might be some workforce indicators which suggest that things are not all going well in a particular service. Automatically, then we will triangulate that to the quality incident data, our restrictive practice data, and so on to say, is this something for which we need to intervene, which often will be to be more visible, to see what support they need, to be present. Fundamental to all of that is the patient care voice. And we do know that there are some services where the patient care voice can't easily be expressed. Those are some of our older people services. Those are some of our services dealing with learning disabilities and so on. And we will also have additional mechanisms there, advocacy or whatever, to ensure that we get that information right. I would like to bring the dashboard to the board at some stage. It is something that ICB is also very keen to look at, because the fundamentals of something like that will be applied to any organization. I think we've got about 2 or 3 weeks for the final version to come to Crossfire Safety Group. And after that, we will start testing it out to see how that adds further to our governance, while identifying healthy cultures or at worst cultures which are getting closed. So I will stop here for any questions.
It sounds like you're doing a lot in terms of having progressive recommendations, and particularly interested in the culture dashboard that you're talking about. And wondered really, we know that you can use temperature clocks to look at culture, but I wondered within that group of people if there's an opportunity to kind of almost have a 360 degree, so you're not just having the same people who might respond, but you're talking to healthcare assistants, you're talking to domestic services, you're talking to peer supporters, so that we actually get it in the round, so that you don't get a kind of too clinical focused culture, so that we kind of think about it from all kinds of views.
So absolutely, I think, yes.
We're just saying yes.
No, absolutely. I think there are 2 bits to this. I think the first bit will be part of the dashboard is hard measurable data. That is the starting point. And the second point is very important we talk about is that the real soft intelligence, which the initial, what has been the problem we have is we've got all this information now. We've got so much information which comes through, but what we don't know is how to use that information to make sense of what is going on. So what this will do is, this will give us early indication with the hard data, which includes staff experience data, patient data, incident data, quality data, for us to quickly go. The first thing we will do is that, gather that soft data in those services. If we don't have it, then decide the next steps.
Questions, comments? Church on the show. Are you going to bring us into the?
Yes.
I think for me, just a reflection as you were going through that the church is, one hand it was heartening, possibly with the slight exception of the dashboard that you just mentioned, but there was nothing on there that we haven't talked about as a board several times. So there's nothing within the Shannon report that would be a shock to us. I guess the question is whether we've got the right degree of pace attached to some of those things, and we're moving some of those things forward with the right degree of urgency and importance, recognising that despite being a big organisation, we've got limited resources and all public sector organisations do. It's about how we're tackling those things at the right pace for me. But as I say, I think we're as a trust. One of the things that you said early on was that the trust that was subject of the report wasn't taking seriously enough the recommendations and the like that were coming from reports and the quarters. The fact that we're bringing Shanley to the board here demonstrates that we are outward facing, but we are looking at ways that we can improve, not just from our own, but from other organisations as well. But I do think it's important. All of the things, if we did all of those things and then set recommendations as a trust, we would be absolutely flying. So it's about the pace and the effort. Okay, do you want to move us into the?
Thank you. Can we have the next slide, please?
It's just gone off.
So, Judge,
No, I'm just, while Kirsty sorts out to say something about, so I think that is really important that against those things that have identified, Rajesh has highlighted, very clear about the how and when. I think the important thing about how that report is what Rajesh has done and what the team have done around that is bring together stuff that we were already working on largely. So this is stuff that's in our annual plan, this is stuff that's already there. And what we don't have is a place where a report comes out, we suddenly get a reaction plan that says, well, we're going to do all of this, and then you've got another report that says, then we're going to do all of that. So it's how do we keep bringing all of this together? And if we're doing the right things, and that's almost for me, is this a test that we're getting our strategy and our plan right? That when reports like this come out, we can say, so is this something we're already thinking of? Because if it's not, and it's important, should be asking ourselves the question, well, how can we have that on our radar? And I think that's the big thing for us. So the most important thing, but actually a good thing for us is we've looked at this and we've looked at what we're doing and saying, yes, it fits. And I think that's a good test for us to keep. And if we don't get to that position, so why not?
It's not coming on, Rajesh.
that's very awesome.
It's not coming back on the screen.
Oh, the
The presentation.
next presentation.
Well, I've got it. Oh, not everyone will have it.
Yeah.
Oh, sorry. So it is, but we can't. So what we're saying is we can't see the presentation on the screen.
But the slides are in the board pack on the website.
All right. So
They've got the
people,
link to the board pack on the website.
okay. So you got nothing you learned. Apologies to people in the room. There's somebody else in slides on me. Oh, can you see that?
Right. Yeah, I think, okay, so if you've got the slides, and if people have the board papers, then I get with the first slide. Then, so I think the first thing to say is that sadly, the CQC rapid review of the case and situation fundamentally leads to the question of how we look after people with severe mental illness, who sometimes, because of the nature of the illness, do not have sufficient insight to engage with us. And what do we need to do as a mental health sector and society to make sure that we look after them and keep the public safe? That fundamentally is what this report is about. Most of you know the background around it, but following the conviction of Waldo Callocane in January 2024 for the killing of Ian Coates, Grace O'Malley Kumar, and Barnaby Webber, the then Secretary of State, Victoria Atkins, commissioned the CQC to carry out a rapid review of Nottinghamshire Healthcare NHS Foundation Trust. So interestingly, the first two parts of the assessment focused on patient safety and quality at the trust, and specifically at their high secure hospital, which is Rampton, which they had previously seen. And that was published in March 2024. And the final part of the report, which actually looked at the care given to Waldo Callocane, was published in August 2024. And that is why it's relevant and it's come to us here today. So if you move on to the next slide, which basically what it tells you out here is that this is some reference to the first two reviews which the CQC took, and they looked at the context. And why this is important is this context is important for most community services in the country. High demand, high waiting lists, stretched when it comes to access to beds, complex staffing arrangements, poor approaches or at best inconsistent approaches to risk assessment and management, and lack of clear leadership. And some of these are a symptom of huge amount of underfunding into community mental health services. We have, as a country and society, ended up developing more and more specialist services at the cost of really looking after the community mental health services, which are actually the engine room of providing real, safe, preventive care in society. So that is a reflection of where we are. Could we have a next slide, please? With regards to the quality of care in the first two reports, what they found was three big areas which contributed to this situation. The care planning was really inconsistent. Families and carers were not involved. Again, a message which comes across all the time. And most importantly, the third bit, which is going to get a lot of scrutiny now, that treatment for these people was not adherent to the mental health code of practice or to evidence-based practices. And that is going to be a big finding. I'll come back to that at the end amongst the recommendations. We move on to the next slide. The slide which talks about recommendations and observations. So following on from the CQC report, they made some recommendations specifically to NHS England. And the first recommendation was that new guidance is published by NHS England, along with help from the Royal College of Psychiatrists, to deal with people with complex psychosis and paranoid schizophrenia. They have given them 12 months from the date of publication, which was August this year. Within publication of that guidance, provider organizations will be given 3 months to say where you are with that guidance to effectively manage people with complex psychosis, as they call them. There are other recommendations to NHS England about looking at the shortage of mental health staff, integration with other services, including the police, and improving the data. If you move to the next slide, this slide specifically talks about what we need to do from an organizational perspective in looking after people with severe mental illness. Proper diagnosis, purposeful admissions, risk assessments, care planning, effective care planning, engagement with family, medicines management, and discharge planning. There's one thing which I want to highlight here, which is quite significant and new, is medicines management. What CQC has recommended is that NHS England strengthens the guidance to clinicians in the community of how they use medication, specifically highlighting the use of depot medication versus oral medication. And the second thing they've highlighted to the to the NHS England is, which has got relevance to our mental health legislation committees also, is they review how the legislation which is used in the community is effective in delivering medication in the community. So that sounds confusing. What they're basically talking about is the community treatment orders. The CTOs are the framework, the safety net for getting people with severe mental illness to ensure they engage. So I think they have asked guidance from NHS England to give to providers as to how they would be much more compliant with the CTO guidance in the Mental Health Act. We move on to the next slide. So this slide talks about the relevance for CNTW in the context of community mental health transformation, taking the learning from the Valdo-Callaghan case. So there are a number of bullet points which I've highlighted, and I'll quickly go through all of them, given that some people might not be able to see the slide. Fundamentally, first, community care has to be personalized and involve families and carers. And that is the basis of our community mental health transformation. Secondly, it has to be integrated. That is what is in our model of care. And we will ensure, as recommended, that the police where required are involved also. Third bullet point, we need to do a little bit better. Crisis teams, early intervention in psychosis teams, and community treatment teams need to be working quite closely. When it comes to this group, we still have areas when there are silos in how these teams operate. The fourth point, there is some debate at the moment who has key worker responsibility amongst various organizations. This refers to the somebody, a point of contact who will have a therapeutic relationship with the patient or service user. We are very clear. When people are in need, when people have such needs that they need assertive involvement, it will always be us. And they will be in what we call in a model of care, the green or the orange group, which is about those who have needs which are such that they require ongoing care, support, and so on from specialist mental health service. The next thing deals with evidence-based treatments. And we also have to improve on the psychological treatments we gave to this group. Medication management. We are doing a lot at the moment with depot medication, and some people might not be aware, but there is a new group of depot medications like olanzapine depots and so on, which are very different from the previous ones, which the side effect profile hasn't been as good. So we're looking at how those could be rolled out instead of the previous ones. And of course, clozapine. If we know that we still have many less people percentage-wise on clozapine compared to many other parts of the country, and that can, be quite a significant change to people's life and income. And the final two bits are also about how we manage people waiting for services and how we learn from incidents. The next part of the presentation is briefly to give you an overview, and Ramona is going to lead on that. James made reference in his chief exec report to the ICB having written to us asking us some questions about how do we assertively manage people who are under our care. They asked us a set of questions focused on practice and policies. We've done that piece of work led by Ramona and operations. She will give us a bit of feedback on that because there were some prescriptive asks in that letter, and also to show how all that links into finally our model of care for community mental health transformation. I'll hand it over to you now.
Thanks, Rajesh. So just to build on that, and you'll see with the slide that starts action 1, I haven't included all the detail, but it is quite prescriptive what NHS England have asked ICBs to lead on, which is providing assurance that there are clear policies and practices in place for patients with serious mental illness. So we have done an initial review of the policies that we have, and you can see them included in there, which I won't pick out all of the detail. But we've spent some time through our quality meetings around asking ourselves a question around how assured are we that these policies are fit for purpose? How assured are we that they're working well? What are our audit arrangements around those policies, and how do some of the practices differ across our 4 main areas in terms of our localities? We've had a summary which is included in the next slide around the processes that are in place. Again, I don't tend to go through the detail of that, but I think it's important in advance of the ICB oversight that they will be undertaking with us. They're going to come and do a desktop piece of work before the end of September. I don't think we've got a date confirmed yet, but we're working with ICB colleagues on doing that. We haven't waited for that process. We've already kind of looked at our policies ourselves. What do they look like? Are they adequate? Do we have areas that we need to strengthen? If you go on to the slide, which is headed challenges and themes, we did have a discussion around some of the areas that are a challenge for us to feed in those ICB discussions, particularly around the critical importance from the Nottinghamshire Learning, which is around ensuring we've got that real clarity about agency and multidisciplinary teamwork and being around the table, particularly which agency owns and leads that discussion, which we know can be a challenge for us, but that is important for us to be clear on and to get right. And making sure that we have those real robust processes in place for ongoing engagement. And you can see the summary that we've collated there. I think there's good practice across all localities and some areas that we need to spread just from looking at how well the policies are implemented across the trust. We have agreed to conduct an audit in some of those areas. That is quite a rapid audit really for us to get assurance around how well they're working, particularly in the context of the MDT discussions that take place within those respective teams that we just talked about, EIP, crisis, CTT. How are we confident that the MDT discussion is looking collectively at those needs and what gaps do we potentially have on that? And you will see that I have included a summary of the 5 key messages that the ICBs will be focusing on when they come and do a desktop review with us. which is the key messages around service users. Services have a duty to engage with people with SMI and their families and carers. Now, we know from some of the themes around learning that has been an issue for us with some of the incidents that we've had, and we've got a piece of work focusing on that right across the board in terms of our engagement with families and carers. That we've got intensive and assertive community care in place with dedicated staff, and I'll touch on that in a second in terms of our model of care. No wrong door approach, and we've got a huge focus on that in terms of our community transformation work with all our partners, which remains a key area of focus in the community transformation steering group. But also that we get the continuity right as well within our model of care, particularly for this patient case group, care group, and that we've got a holistic and engaging care model in place as well. There are 11 areas that the ICBs will be focusing on with us as part of their sort of desktop review in terms of how those intensive and assertive community features are working in practice. I'll not go on through those in detail, but those are the areas that they're asking us to look at when they come and have a look at how we're managing that particular patient group from a community care perspective. And just to touch on the last slide, and Rajesh has mentioned our model of care. And I think this is really important because the work that we've already commenced, particularly over the last 12 months, absolutely harnesses the focus around this for us in terms of our approach to the people, particularly in that getting more help and recovering and living well with SMI. It's a key feature in our model of care. And this isn't about stepping up new services, it's about how we have that confidence that our community transformation approach, particularly around that model of care, is working and working well. And where we've got challenges with that, which we know we do have in some areas, that we're really clear about the plans that we're putting in place to address those. The final slide that's in the pack there, which I think is just important to reference, and we have got a separate paper on it. The work that we're doing around the hub model in Whitehaven and some of the work that we're doing through our pioneering teams is front and centre to delivering some of the changes that we need to make around particularly those people with SMI in our community. We've got a real opportunity to see how that model works in practice and guide some of the areas of work that we know that the ICB will be asking assurance on, but also ourselves as well. So thank you. I think I've covered all the key points. Rajesh, if there's anything you wanted to add on that.
Happy to take any questions.
Or comments on the
Early on, you said that it's important that it's the correct diagnosis early on. How are we as a trust ensuring that we get it right first time
So
on the diagnosis?
we are trying our best. It's the best thing to put in. I think there are certain. We have gone through something which we are referring to as kind of a trusted assessment way of assessing. So when you have the first assessment, it's the best assessment. Within the pioneer teams, we're moving much better towards that. But sometimes when you leave it to individuals, you always had a margin of error. So some of the systems we worked around. So for example, you've got a new assessment form on our electronic records, and we've got a new risk assessment framework, which everybody will have to follow now, which will give us that bit of assurance that we will do that really well. But if we still have difficulties, the integration model still is not good enough in all parts of the trust. So if we still have cases where we might not do that very effectively, and that's something we really watch. The pioneer teams are giving us a lot of insight into it at the moment. So the learning from that, hopefully we can adapt it.
Yeah, I think I said in my introduction to Chief Executive report that I think a lot of the issues in the public locality are systematic in terms of the way we work. So there's a lot of high pressurised working, so there's a lot of working at speed. Actually, to do this right, you've got to spend the right time at the right time with the right individuals, and that's the core of our model of care. So I think again, this is an example where we look at the work we've done on the model of care. As Ramona says, we've identified the answer in that, but what we're trying to get to. The issue is how do we manage as well as we can with the current systems. And I think all of the work we're doing in order how do we make that work as well as we can. But really the answer lies in that more strategic approach is how to make much more fundamental changes to the way we work in partnership and the way that whole system works. Well, we really get there, so we'll start delivering on that. But we'll probably do what we can in the meantime.
Two points really. One is, I suppose, a concern about the new mental health bill, particularly about community treatment orders, because they're primarily about engaging and medication. And if they're not there, we've got a real issue, and it's very much dependent at the moment on details. We see so many coming through the panels. So I think that's really important. I think the other thing that is an issue, particularly for carers and families, is that quite often service users, patients, clients, whatever you wish to call them, will not want the family to know what is happening to them. And I think it's really important that although we have to definitely respect that view, that does not mean we cannot take information from those carers and families. And I think that's really important, that we don't just disregard, that we act, because they give us that that information that's so rich in helping to build that. And hopefully as people progress through their illness, through the recovery models that we use, they will be more engaged with the families, and it would be a shame not to have done that and be really clear with every member of staff. You can accept information if you can't.
And also, like you were talking about earlier, I don't think the mental health change the mental health act will go through smoothly. I think it will be changed potentially quite significantly in the light of the development campaign. But I'm not sure that will be for the best. I don't think the risk that it comes off the more restricted. But I think there will be enough concern around the things that you're talking about that they will have a quite a tricky passage and will be quite significantly over.
There is some history of that in previous incidents.
Really important that the board heard those two reports, particularly actually within a public board meeting. Insofar as obviously the first report was very concerned about the organisation itself and what we can take from the way that an organisation is. That second report obviously arising from a huge tragedy and how the system needs to work to safeguard people and how we need to operate within that, taking the learning from it. So I think it's important that we use reports like that, and as James said earlier on, that we're not knee-jerking for whatever report or whatever incident happens, but actually we're taking those things and we're looking at, do our plans, and are our plans consistent with the recommendations that come out of these reports, and if they're not, then where do we need to change, where do we need to alter? So quite reassuring that we've got some good plans in place, but clearly an awful lot of work to be done. So, okay, I'm going to move us on to 2.4, which is the integrated performance report in the section around quality care every day. Anything you want to pull out of that, Sarah?
No, thank you, Chair. So I'd just like board to note around the commitments to our carers and patients in terms of our headlines. The three areas of questions relate to how was patients' experience, how was the care we provided, and did you feel safe? We've seen a change in our way we record our patient experience data, moving from flexible use survey to our new Your Voice survey. And since we introduced the new Your Voice, we've seen a real increase in the amount of people who are responding via that process, because we've introduced different mechanisms through not only postal but through text messaging and online responses. So we've seen an increase in that. In terms of the outcomes that we've got demonstrated for this IPR, we've seen from Friends and Family Test, performance was slightly down from the June at 84.5%, so just below our 90% target. But hopefully, as people are responding more to Your Voice, we'll see that increasing. But we are looking at specific areas where we can have some focused conversations. In terms of do you feel safe, this remains our best performing question, with over 90% of people stating that they felt safe during their care, which is great to hear. And in terms of care provided, we have seen a slight increase from our June data, up to 87.9%, just below our 90% target. But again, hopefully on an improvement trajectory with those numbers. So that's all in terms of commitment. I'll hand over to Rajesh, who might want to pick up some of the restraint data.
Thanks. I mean, there is a huge amount of work happening at the moment in relation to restrictive practices in the first. But what I wanted to draw from this report was there is some reference made to road restraints and improvement, when actually there has been an increase in those incidents this month compared to the previous month. So although there's been an improvement over time, it isn't really an improvement. But I think what people need to be aware of, this relates to two people in one of our wards at the moment, and that's been very, very carefully managed and being supported. And the other bit just to highlight is there has been a slight increase in the assault incidents between patients, and we're just monitoring that very carefully as to the nature of the service and the particular people who come in, just to make sure that we do everything to support that and reduce them.
Yeah, I'm going to have to power pace a little bit. I had all 5 minutes together that the remaining agenda item we've got won't be finished till after 5:15, which is too long. I don't mind running by 5 minutes or so. So if we can go to 3.1, which is under our strategic ambition 3, personal care when and where it's needed. So the community of West Cumberland.
Thank you, Chair. I'll be brief because we have covered this in the Chief Executive report, but delighted to confirm that we are one of 6 areas chosen as part of the national programme to take forward our 24/7 base, which will be in Whitehaven. Plans are all in place now to mobilise and press ahead with this, which completely links to the previous item around community transformation. I'm happy to take any comments or questions.
So questions? But I think it is worth recording a huge well done and gratitude for all the work that went into getting that successful bid. So thank you. 3.2, integrated performance report around personal care. Ramona.
Thank you, Chair. A couple of things to pick out. We have already noted the ongoing challenges, particularly around the neurodevelopmental weights for both children, young people and adults. We have got the second meeting with the ICB, as I previously alluded to, taking place now in relation to what we can do in the short to medium term around the rates and time position for that. We did do a deep dive, as already mentioned, around crisis, and I'm hoping that we'll see an improvement probably the end of September position, particularly in the central and north localities around the very urgent referrals, given the work that we're doing there. We did see a slight dip in performance around our out of areas, but recovered well and fast. With that, we have one out of area as we stand today, with that in terms of our bed pressures, but we have seen a sustained improving picture around our PLT performance, which I think is really positive given where we've been, particularly over the last 12 to 16 months with that. Again, happy to take any questions on the detail, Chair. Thank you.
Yeah, we're going to move us into section 4, our strategic ambition around being a great place to work, and leading off with Brendan, chairing our people committee.
Thanks, Chair. I'll just run through a few headlines. Obviously, the range of things that we cover in the People Committee is huge. So what we have agreed, myself and Executive Director Lynn, is some key areas that we want to focus on, that we'll do regular sense checks on over the year. And there are our work on culture, just culture, and how that's embedded, our workforce establishment planning, leadership development, improving performance on our new staff training targets, because we've revised those, because it's been a problem for a while, and we have actually positive movement on that, which I mentioned, but also to keep checking in about how service user care reviews influence our priorities and our programme of work. And I know that's actually something that's going to happen in all the commitments, but it's something that we're trying to raise. I'm not going to do the large range of performance reports, because I think you'll think I've mentioned some of them. Couple, so I'll just want to raise a couple of issues. So as I say, on the positive front, on issues like clinical supervision and placement training, been stuck for quite a while, but we are actually seeing some dramatic turnarounds on that. So that's really positive to see. I also want to raise the work on the workforce establishment in particular. We now have 2 workshops per year where we do a deep dive, because we don't get most time to do that in our committees, and that's going to be the main focus of our November workshop, which was great. Right, so you're really slow at scrolling today. So on employee relations, we've had a reduction in the number of cases, which is obviously very positive. There's been a lot of work done on an approach around resolution as opposed to things going through a standard grievance procedure, and that seems to have made a real impact. The flip side is on the I suppose the negative side is that we still have a challenge around timescales. So one of the biggest complaints that we'll have is once processes start being grievance or discipline, it can take too long. That's been a kind of source of kind of staff dissatisfaction, but Lynn and the team are actively working on that. A couple of other good points to just raise on turnover. Has been improved over the last 2 months. So this is our members of the public, this is our kind of staff churn. So how many people join us versus how many people leaving us, and that has improved recently, which is positive from a workforce point of view. And also, one of the main problems that we've had for quite some time has been our training compliance. And whilst we still have a kind of way to go, we have made some noticeable improvements on particular kind of core training. So it feels that we're finally kind of beginning to unstick ourselves on some of those problems that we've had, particularly post-COVID, getting training back up and running. So that's been positive to see. We've also had some positive changes across our equality, diversity, inclusion work. So we've seen that around the numbers of Black and ethnic minority staff, overall numbers of the trust increase to 11%, which is again good to see that our staff is reflecting our communities. And I'll leave it there, I think, as far as highlights. Obviously, the report.
And did you want to come in under the IPR? Did you want to come in?
I can actually do them both in one if that helps for the next, because just because Brendan's already mentioned it. So Brendan has mentioned the improvements in appraisal, all the training metrics and clinical supervision. As we discussed at the people committee, there might be, as there normally is during this period, a dip in those because of the time of year it is. So we're seeing improvements, but in particular for clinical supervision, because of the frequency of the clinical supervision, that has dipped again. But I think that now the summer's over, that will improve. So I think overall, an improving picture. I just wanted to mention 3 pieces of work, because one is very much linked to the conversations we had at the people committee, but it also links it to the Shanley report and the annual report on work that we've already been doing. So the first one is we are about to relaunch our Give Respect, Get Respect campaign. That was something that we brought in 2 or 3 years ago. It's a priority again as part of our EDI objectives, and to ensure each and every individual in the organisation is treated with dignity and respect. So we are about to relaunch that. We've also recently launched a bullying survey, and that again is in response to some of the feedback that we get from our previous people guardians, the staff survey, and just general information as it's fed to us. So we've had closes in a week or so's time. We've had over 1,000 responses to that. So again, it's thinking about how we can use the intelligence from that to help in our work moving forward. And then the third area is, as part of the Quality People Pulse last month in July, there was a focus on speaking up. So asked a number of speaking up questions, which we're starting to analyse, but I've put into the Afraid to Speak Up to report that both through the people community and then through the board in November. And that again, we've been talking about that with our guardians over the recent months. So let's just triangulate some of that information. It's all linked to both all the culture stuff and the annual plan.
Any questions or comments while we're not Brendan? Okay, so I will move us on to section 5, which is our strategic ambition 4, which is around being sustainable for the long term and innovating every day. And so our Resource and Business Assurance Committee Chair Paul James, as I said at the beginning, able to join us to this apology. So Kev, our executive lead, is going to cover that one off for us.
Darren, I'll be in the given the timetable we're working to this afternoon. So we spent most of the committee looking at the 24-25 financial position, particularly looking at how we allocate any unidentified savings attached to the plan that we submitted this year. There's an update that follows this, which I'll work through detail of that in that report. And we also received a number of assurance reports around estates, including the utility report and the place report, which is the patient-led assessment of the care environment. We responded to a query from the previous committee from one of our governors around agency expenditure and usage. There was a specific report which highlighted the performance on that and the improvements we've made over the last couple of years on that one. There were a number of benchmarking returns and results from previous collections that were reported and discussed with the committee, and we looked at our underlying financial sustainability as well. We did spend a significant amount of time discussing digital as a new area of focus for the committee, particularly the digital maturity assessment, where we looked at specifically the leadership and governance domain, and we'll be working through the implications of that assessment to bring forward to board future in terms of how we manage digital going forwards from a governance perspective more widely. We assessed the board, we looked at the board assurance framework, and we recommended to the committee that we de-escalate temporary staffing risk and recommend that we introduce following discussion with the committee that a new risk was included, which was around the overall affordability and size of the workforce as opposed to a subset, which was a temporary staffing for pay expenditure, which the committee accepted and has proposed in the back report, which will be in this meeting. The board are asked to note the content of the report and to ask for any assurances and further assurances or previous asked the board. Chair.
Thanks for that. Any questions or comments? Thank you. Oh, sorry, Rachel.
In 3.3, it says that the unidentified efficiencies has been reduced significantly. Is that because you found efficiencies?
Are you looking at the 5.2? We're on the next item, I think, aren't we?
Oh, sorry.
Sorry.
That's all right. We're about to move into 5.2.
Kev's forewarned now.
I know what you're going to ask. Shall I move on to the next report? So the next report is the month 4 finance report, which is an updated position from what was considered the committee, which is the month 3 report. What we've seen is an improvement in the month 4 period of around £2.1 million. So we've moved ahead of plan. That's as a result of us reviewing our year-end accruals and some of our liability, which provided the benefit for us ahead of the expected timescale, which was at the end of the year. You can see that in some of the graphs in the report showing the phase of the plan versus how we're performing at the moment. To answer the question around the unidentified efficiencies, so we did have £6.2 million of unidentified efficiencies in the plan. At month 4, that's reduced to £3.9 million. I think in the previous board meeting, Chris will give an update on that. So we have allocated some of that unidentified target to things like the land sale that we're expected to complete. So that efficiency will be met non-recurrently, and that explains that reduction in month 4. We also expect the residual £3.9 million to be well, it will be allocated in month 5 reporting, as we've got several items that we're expecting to deliver on there. So we see an improvement in the specialist care forecast of around £1.6 million. So that's an improvement there. which will help that position. So we're allocating some of the target there, as well as we've requested some additional funding from specialist commissioners in particular, which are expected to help bridge the gap as well. So when we come to month 5 reporting next month, or whenever the next cycle of reporting is forward, you should see that being eradicated, and the only risk we should be managing then is in-year financial risk and future year financial risk there. Agency performance remains in a really good place, so it's less than £1 million, hence the de-risking, the de-escalation of the risk that we've included on there. And although we're making good progress with reducing the size of the organisation from a workforce perspective, that needs to continue at some pace, hence the recommendation to step up another BAF risk around the total workforce, which is included in the BAF report later on. Trust remains in a positive cash position and is ahead of its plan on that one, but the cash position continues to reduce. We do expect to end the year with a positive cash balance and have no requirements to borrow any money from emergency sources in 24-25. And the capital programme has some slippage on it at the moment, which is causing us to review forecasts on capital, especially in the light of the commitment the board's made on the campsite, which we need to have a commitment on that capital programme at the end of this year. So we are currently engaged in that and expect to complete by the end of September. That's it.
Lot in there. Any questions or comments? Just by way of some explanation to those of the public who might be watching people in the room, is that before this session we do have a closed session, so a lot of the information certainly contained in that financial report, as a board, we've already heard. Whether you reaction for the second time today, just people aware. Anything additional to that, Kev, that's been looking to the performance report? No. Okay, thank you. In that case, I'm going to move us on to section 6, which is our strategic ambition 5, which is about working with the 4 communities. And again, Vikas Kumar, we have another executive director who chairs that committee. Some apologies to Sam and so Debbie Henderson is going to come to make the reports.
Thanks, Chair. I'll be quick and fine. So last year, we were fortunate to be successful in terms of an NHS charities to get a bid for temporary funding for a post to support the charity. I guess in the context that the charities never really had any full dedicated support in the past. And that post came to an end in July, end of July this year. So we discussed at length the value added by that post during, I think what's fair to say, has been a relatively short period of time, a 12-month period, in terms of the work that it's done to rebrand and relaunch the charity as a whole, deliver year 1 of the charity strategy that was agreed last year. And that was primarily around, in the initial period, raising the profile of the charity both internally and externally, and working to develop external relationships, of which there have been a lot developed this year. And hopefully you've all seen that through our community channels, internal and external organisation. So the committee agreed to fund the role for a further 12 months, but with a view to the role becoming self-funding in the future. So we're keeping an eye on that going forward, but hopefully there won't be any issues as we move forward. Vikas as chair also touched at the committee on the importance on looking at how we focus our energy and resource, not just on general fundraising, which is clearly important, but also on how we, I guess, diversify our income streams in terms of opportunity around things like grant funding and bid submissions in the future. So an example of that is where this year, through that post, I'll be minded to say that put a lot of effort into that bid. Actually, it was a lot of effort. We were successful in accessing over £150,000 to support new projects in our patient services this year. So that's the example of the difference that some resources capacity can make, I guess. At our next meeting in October, we're going to be reviewing our strategy in the longer term perspective, particularly around how we can align the charity objectives and opportunities to our objectives around EDI and health inequalities, particularly thinking about how we can support, I guess, those not just within the organisation and the service users and carers we have internally receiving our services, but also how we can support those who are most disadvantaged within our communities as well. So we're going to be having a bigger discussion on that And it might be that we have a bit of an open invitation to other board members as well if they want to join that conversation. And I think that was all I was asked to highlight at this stage. So,
Thanks. Any questions or comments? I don't know them saying it's always a lovely interlude in the meeting, isn't it, to hear about the work of the Charitable Funds Committee and it is going from strength to strength. Louise's leadership and now big assistance is taking it on for just on this really some really fantastic work coming up. Good to see the chairs getting in there as well. Yeah, across the trust which is. I'm going to move us on to section 7, which is governance and regulatory activity, and our audit committee. David Arthur.
Thanks, Jeff. Well, we met in the middle of the riots. So unfortunately, Sarah, who was due to give us an update on duty capital training, long-term segregation, CQC visits, was unable to give us a report. She was tied up with response to the riots, and rightly so. So we will be having a sort of written follow-up on those issues. As far as I'm aware, that there aren't any great issues to be report to us. We also got an update on the forward work done on the onboarding process and a little bit of work that been identified for internal audit to do to identify weakness. This was one of the internal audit, relooking at the improvements we made and everything seems to be moving forward and going really well. So thanks to many for that. I had a lot of detailed assurance update from RABAC, which during that time we've heard already from Kev that there was a amendment requiring of the custody of the bathroom. Looking at the risks on the risks that we had previously identified as being an issue around protection staffing and agency staff. And on the basis the trust seems to have that well managed and well under control to downgrade that risk, but that we felt there needed to be an escalation on the risk about overall the voluntary recruitments and the substantive staffing levels that we've got, and the implications of that means in terms of financial performance, not just for this year, but for the medium-term plan. So that was also covering the things in our updates. We had a general update from SARS in terms of their terms and conditions for things. This currently is that for intermediary solutions, which is straightforward. Got an internal audit progress report, and out of that, the one thing that we have already brought up to the board's attention was that there had been a slowing down previously of responsible executive action audit committee recommendations and the response that had been done. Work had already started on that. We had already reduced from 45 issues down to 18, but we believe that that's fallen further again, hopefully by the next meeting, we'll be down to everything being by to date. In terms of the current internal audit with limited assurance about the section 136 health and safety and mental health act recording and reporting, so there will be some forward work done on that to make sure that the recommendations produced by internal audit carried through and obtained from that point of view. And then the only other thing which isn't in this report, but we did discuss and did bring into board board's attention, and that is around the potential sort of governance gap on digital innovation, which has been brought to everyone's attention and will be brought into full consideration going forward. Well, last, one to questions.
Any questions or comments for David? I think the only other point probably not mentioned at the beginning is that Robin Earl as a new non-exec director, probably just a no thanks to the council of governors actually to agreeing the period handover that's now taking place between David as the current managing chair and Robin who's now joined us as a new non-exec director. So
fully again member of the community.
Excellent. Take us to item 7.2, which is the BAF and for the students' framework for the corporate risk register.
Few things to note. So as always, I'm going to see any when you report the back risks all being reviewed by the relevant subcommittees. And have already been referred to in the known right as part of the updates. The report also, just to flag now, includes the risks held on the corporate risk register. That's the risk register that sits beneath the board assurance framework. So essentially, those are our highest rated operational risks across the organisation that are overseen at exec level. So as we all know, risk registers are live documents. They're updated on a weekly basis across the organisation. And section 2.1 details those risks that have been added to the corporate risk register since the committee meetings have met in August. There has been, it's fair to say, a really robust review from the care groups and senior leaders in the organisation over recent months in terms of that. What's the content on that risk register in terms of what we're talking about and dealing with right now, particularly in terms of the inclusion of risks associated with the impact of demand and access, waiting times, and crisis services, for example, which we've been talking about for some time. So discussions taking place, still taking place through executive management group on an ongoing basis in terms of what are the actions that are being taken to address those risks and what actions are still outstanding in terms of preventing us dealing with them fully. The BAF and corporate risks have been aligned in the report where appropriate, and just to give further assurance, I guess, on the work that's being done to manage quantitative operational level to manage the risk at a strategic level, given that they're so closely interlinked. As Kev mentioned, there's the recommendation from the Resource and Business Assurance Committee to de-escalate risk 2540 associated with the impact of agency spend, and the proposal to work on, I guess, and include next time an additional risk on overall sustainability in the context of workforce and staffing levels overall. I think that's all I wanted to say. Share any questions or that's an approval of the de-escalation, please.
Yeah, sure. Any I'll assume approval unless anyone is raising any. So it's agreed, thank you. Any further questions on the back of this? In that case, that takes us to any other business. There is one note item before I get to questions from the governors or members of the public, which is UK Global Inquiry Module 1 report. So
all the information is there. This is the first module reporting out from the Global Inquiry. So for information, there are a number of modules that will be reporting out over the next number of months and years. But just for assurance, we have included the updates contained within the inquiry module into the pandemic plan. So that's integrated in there. We'll continue to revise that as the outputs from the modules report. But there's nothing more to say there other than this was around the response, resilience and preparedness for the pandemic. So government level rather than trust level at this stage.
no, thank you for bringing it. Thank you. Right. Do you want
Just how we can do a couple of very quick by the businesses, but they'll
quick
really quick. But the first one's nice. So the first one is that just to wish luck for, we're just been talking about the Shine Fund, and we've got 9 people running from the trust to raise money for the Shine Fund on Sunday. So I think we should, as a board, wish them luck and hope there is loads of money.
Give me away, but maybe that's
No, they're going to say get the sponsorship across the year, but we'll do that too. And the other congratulations I think we need to give is to Greg Stevenson, who is a member of our Courage Team Veteran Service and was part of the double sculls team in the Paralympics rowing. We won gold. So we have a member of staff who was a gold medal winner. So well done, Greg.
To be fair, those two were both worthy of additional question. Okay, so in terms of questions from the public, I will open up to the room, but there is a question from or a point I think from Reagan, one of our carer governors, for wanted to talk about, which was that she's noted some of the what do you call hospital patients at risk, the Edenfield Centre reports, etc., noted some of the recommendations, some of the reporting that goes on in the likes of Panorama programmes. And so basically she's valuing the progress of CNTW and more in-depth learning from such accounts, but obviously knows that some of that learning comes from terrible tragedies such as Edenfield. And I think Fiona's encouraging that we continue to do that, but we also look at some of the positives as well in terms of learning. And she's written a note here that I don't intend to read out in the meeting, but we'll include it as an addendum to the minutes so that people can see the points that we wanted to make. And so with that, any other questions or points from members of the public in the room?
Just the age, once around now, the age of the problem. Does that how you pronounce it? ADHD. So, Thomas Warbeck raised this problem on LBC Concept Centre. I was quite shocked because if this situation is going to be sorted out, it's going to have a knock-on effect with the children's schooling, the correct support, the correct, also the help in the workplace for adults. It's going to be it's a difficult situation. It's a problem, and it needs to be really sorted out quickly. And another point from the personal aspect about the situation. You talk about bullying. I did a subject access request 2022 and information was omitted because it was across the state party. And in the core documentation from a person who I've never ever met said, I don't believe anything Nicholas says, no smoke without fire. I did another subject access request in 2023. The names were given to me that were belonging to the first one. Knowing that, the trust has been having meetings with my sister, my dad, and my mum. My mum had dementia at the time, but she wouldn't know what the meeting was about. In this information, it stated that they wanted to be looked away because of frightened my ramifications. I have no contact with family. I'm pretty disgusted. I am disgusted at the way information is written about me, saying that I'm a low achiever. I've got 7 CSEs. Now, no one has come to me to talk to me about these situations. Yes, I've got 7 CSEs, and I'm very proud of it. Being in a special school for 2 years around the 7 CSEs, and all the school would have given me that chance. Now, mental health, I feel now is being lumped wrongly. The same birth defects that I've had is mental health. No, it's not. It's birth defect, not mental health. People bullied me. They've written in information to say that I'm the problem in the street. I'm not the problem in the street. The neighbours are a problem in the street. They target me because of my inabilities, and so do the police. I don't think, no disrespect to you, Mr. Best, I don't think mental health should be put in the police's remit because there is blatant misogyny from the police. There is blatant misunderstanding about mental health. They've told me I can't make a statement against a family member. I don't have the capacity. Where do they get this information from? And I've been safeguarded, but I'm not told about these things. I've never been infected, and I think you've all got to look at yourselves. I'm not as a system. Yes, I had a breakdown after my major operation. I got myself better. I had mixed up, but I got no support. But yet, these first in the mental health, there is blatant institutionalized discrimination from people. And I'm sorry. We've had it at the mental health hospitals. We've had incidents, another incident where a woman had been videoed by a member of staff in another hospital elsewhere, and the police won't take that report seriously. But it should be taken seriously because she has every right to make a statement with the correct support put in place. And I want to be out of the system, but I can't be out of the system when all ones want to be in the system, and the ones that should be in the system, I can't get them into the system because I have to have their consent. But yeah, they can have meetings about me without my knowledge and without my consent. That is totally wrong.
Thank you. Thank you. I think it's quite clear that you've got a number of grievances, I think, in there, and understandably so from what you've said. In terms of dealing with the 2 points, I think around the ADHD that you started with, I think that is recognised certainly by this board, by this trust, as being a very important issue in the way that you describe it. I think the only thing we can't commit to do is to try to do it quickly, and we use the word quickly to sort this out. But I think there's nobody in this room who doesn't take it extremely seriously. Would like to talk.
Yeah, because it's going to affect the child's school. They're not going to get the right support. There's a lack of support workers in mainstream education, and I don't. If that person, because it's going to have a very bad repercussion on their mental health, because at one time these children could go into special schools. Well, I shouldn't say special schools, but certain schools.
I apologize, but within a meeting we haven't really got time to explore it all. But I think the points acknowledged, I guess, is the way that I'm going to say it. In terms of the second point, and the series of points that you made around the way that you've been treated and the way that you've been dealt with by CNTW in some instances, but obviously you went into other aspects as well. I think the best thing to do with that is, we obviously discussed before the meeting, I'm going to ask Debbie to get in contact with you, and then we'll arrange a meeting so that you've got a proper opportunity to wear those things, and we can distill from that the things that CNTW were able to deal with and help you with, and those things that
You're so negative.
Well, let's pick all that up, and we'll sort of it out, I promise, so that we can discuss those things in a more private forum. Because I'm conscious this is a public meeting.
Yeah, it has to be raised that.
Yeah, and you've raised it, and that will be the points that you've made will be part of the minutes of this meeting. So the fact that you said will be there for people to see. We can know. So thank you. Any other comments or questions? No, in which case I'm going to bring the meeting to a close. The next board meeting in public that we have is on the 4th of December. Christmas Day. So thanks everyone. Thanks for your time.